Okay, so I went ahead and made a couple of slides on hemostasis. I pretty much have the first part down, primary hemostasis, but I still find myself getting secondary hemostasis wrong, so I'll do a separate video on that. But if you print out this page, I guarantee you it will get you points on the exam. So primary hemostasis is going to be associated with any pathologies that have epistaxis, mucosal membrane bleeds, and petechiae. If someone has petechiae, you're thinking low platelets, right? I'll go into that a little bit more. I put here superficial bleeds. You're going to want to follow their bleeding time as opposed to PT, PTT, that sort of thing. So you're going to need to know what are the steps. They love asking what is the first step of hemostasis. So first step is going to be your endothelial damage. So if this is your endothelium, you have subendothelial collagen down here. You get endothelial damage, and that releases endothelin, right? So after your endothelial damage, you get vasoconstriction. That vasoconstriction causes release of endothelin. So once you have release of endothelin, your Weibull-Piloty bodies with von Willebrand factor and factor 8 are going to be released, right? So I put von Willebrand factor as this blue blur. So if that comes out, it binds to the subendothelial collagen, and it's kind of waiting for platelets to come around. And those von Willebrand factors have GP1B. So once GP1B attaches to von Willebrand factor, see, GB1P, degranulation of your platelet happens. So if you have the platelet, there's two different types. I like to think of two different types. You have one that has dense bodies and one that has alpha. The first one's going to be the dense. Of course, all platelets have the same bodies within them, but I like to think of them separated. So first, your dense body is going to degranulate. So what does that mean? You're going to have a decrease in cyclic AMP, and that's going to cause ADP to be released. Once ADP is released, it binds to P2Y12. Once that's bound, GP2B 3A is going to be increased in expression on platelets. At the same time, you get activation of this platelet. Why is that important? Because it's also going to degranulate. But this one has an alpha body, see? This one has von Willebrand factor, fibrinogen, and PF4. PF4 is important later on for other studies, but for now, these two are important. If von Willebrand factor is released into the circulating system, you're going to have increase in aggregation. At the same time as this degranulation is occurring, you also have thromboxane 2 being released. This somewhat creates a snowball effect. So now you have both of these degranulating. Just remember that thromboxane does not come out of the dense bodies. So if you have fibrinogen released, fibrinogen is then able to actually bind to GP2B 3A. This in the entirety creates the weak platelet plug. So some important recaps for this are the steps here. Endothelial damage leads to vasoconstriction. Von Willebrand factor attaches to collagen. You have your GP factors, GP2B, thromboxane, fibrinogen. Just remember that GP1B, so number 1 starts from the bottom. You go GP1B, 2B, right? 1, 2, 3. They love asking about these. Here's a little more clinical application for you on pathologies. So hemolytic uremic syndrome, TTP, ITP, Lanzmann, BS, and some mixed platelet coagulation disorders. So, in general, these should have an increased bleeding time. Other coagulation cascade problems should not necessarily have an increased bleeding time except for these two down here. So if they tell you the patient has increased bleeding time, or maybe they tell you it has epistaxis, mucosal bleeds, or petechiae, you're thinking low platelets, and it's probably one of these 6 pathologies, or 5. If they also tell you there's a PT and PTT problem, that's going to be one of these 2. I'll let you review these because this is the way that I remembered them. The biggest bang for your buck on this image is going to be to remember that 1B is here, 2B is here, and also that these 2 have increased bleeding time with changes in their PT or PTT. Another side note, the Ristocetin test, remember that it's going to be useful for BS or for von Willebrand disease. Here are some drugs with the action sites that they use. So they like asking these because it's the first step of the primary plug, primary hemostasis. Aspirin, I also remember that ticagrelor is the only reversible. It's the only one that ends in an R for P2Y12. Here's a summary page again. Again, like I said, if you found this useful, I'd go ahead and print this out. This actually got me quite a few points on practice questions.